Hello friends, in this video we are discussing about we are reading about fracture of humerus from snail and mole anatomy. So first of all, let's read from snails. What is written? Proximal end of humerus fracture. You can see here. Surgical neck, you can see here. Anatomical neck. This is all about. This is about anatomy of normal anatomy. This is radius and ulna. Common feature of humerus and common feature of radius ulna. Red arrow indicate Red arrow indicate the direction of displacement of bony fragment on the side of the fracture line and the pull of the responsible muscle. C of pull of the common flexor muscle, D for deltoid, and PM for pectoralis major, S for supraspinatus, sub for subscapular, T for triceps. Let's see. C for what was C? Common flexor muscle. You can see here, medial epicondyle is pulled by it displays downward. C of deltoid, pectoralis major, it displays here, subscapularis, suppressor. You can see it, this is tricep. So let's discuss one by one. Humeral head fracture. Fracture of the humeral head can occur during the process of anterior and posterior dislocation of the shoulder joint. The fibrocartilaginous glenoid labrum of the scapula produces the fracture and the labrum can become jammed in the defect, making reduction of the shoulder joint difficult. Next thing, greater tuberosity fracture. The greater tuberosity of the humerus can be fractured by direct trauma displaced by the glenoid labrum during dislocation of the shoulder joint, or avulsed by the violent contraction of the supraspinatus muscle. The bone fragment will hold the attachment of the supraspinatus, teres minor, and infraspinatus muscle, whose tendons form part of the rotator cuff. When associated with the shoulder dislocation, severe tearing of the rotator cuff with the fracture can result in greater tuberosity, remaining displaced posteriorly after the shoulder joint has been reduced. In this situation, open reduction of the fracture is necessary to attach the rotator cuff back into place. Lesser tuberosity fracture. Occasionally, a lesser tuberosity fracture accompanies posterior dislocation of the shoulder joint. The bone fragments receive the insertion of the subscapularis tendon, a part of rotator cuff. Surgical neck fracture. The surgical neck of the humerus, which lies immediately distal to the lesser tuberosity, can be fractured by direct blow on the lateral aspect of the shoulder or in an indirect manner by falling on the outstretched hand. The axillary nerve and the circumflex humeral vessel have close relation to the surgical neck and can be readily damaged in association with a fractured hair. So, shaft of humerus fracture. Next type. The fracture of the humeral shaft are common. Displacement of the fragment depends on the relation of the site of fracture to the insertion of deltoid. When the fracture line is proximal to the deltoid insertion, the pectoralis major, latissimus dorsi, and teres major muscle adduct the proximal fragment. The deltoid biceps and triceps pull the distal fragment proximally. When the fracture is distal to the deltoid insertion, the proximal fragment is abducted by the deltoid, and biceps and triceps pull the distal fragment proximally. The radial nerve can be damaged where it lies in the spiral groove on the posterior surface of humerus under cover of the tricep muscle. Distal end of the humerus fracture. Supracondylar fracture are common in children and can occur when the child falls on outstretched hand with elbow partially flexed. Injuries to median, lateral, radial, and ulnar nerve are not uncommon, although function usually quickly returns after reduction of fracture. Damage to or pressure on the brachial artery can occur at the time of fracture or may from swelling of the surrounding tissue. The circulation to the forearm may be interfered with, leading to Volkmann's ischemic contracture. The medial collateral ligament of the elbow can avulse the medial epicondyle if the forearm is forcibly abducted. The ulnar nerve can be injured at the time of fracture, can become involved later in the repair process of the fracture in the callus, or can undergo irritation on the irregular bony surface after the bone fragments are reunited. So now let's read on more. This was about humerus fracture from snail. Let's discuss about fracture of humerus from Moore's clinical anatomy. This is my personal favorite book, Fracture of Humerus. Most injury of the proximal end of the humerus are fracture of the surgical neck. These injuries are especially common in elderly people with osteoporosis, whose demineralized bone are brittle. Humeral fracture often results in one fragment being driven into the spongy bone of the other fragment, impacted fracture. Injuries usually result from a minor fall on the hand, with force being transmitted of the forearm bone of the extended limb. Because of the impaction of the fragment, the fracture site is sometimes stable and the person is able to move the arm passively with little pain. Avulsion fracture of the greater tubercle of humerus is seen most commonly in middle-aged and elderly people. A small part of the tubercle is avulsed, torn away. The avulsion fracture usually results from dislocation of the humerus. In younger people, fracture of the greater tubercle can result from the impaction with excessive abduction or flexion of the arm. Muscle, especially the subscapularis that remain attached to the humerus, pull the limb into the medial and rotation. You can see here the picture of humeral fracture. Number A, avulsion fracture of the greater tubercle of humerus. So this is avulsion fracture of the greater tubercle of humerus. You can see normal clavicle, acromion, so supraspinatus, infraspinatus, coracoid, scapula, subscapularis. You can see supraspinatus, subscapularis. Direction of pull of supraspinatus and infraspinatus upward. Line of fracture of greater tubercle of humerus. This is humerus. Direction of pull of subscapularis. Subscapularis will pull this way, and supraspinatus and infraspinatus pull this way. Next, transverse fracture of the body of humerus. This is deltoid coracobrachialis, proximal fragment fractured humerus. Direction of pull in this way. Upward pull of the long and short head of biceps of foreshortening and overriding fracture in bicep brachii, long and short head. This is commutate, spiral, transverse, green stick, compound oblique. These are fracture patterns. Fracture of the shaft of humerus result from a direct blow to or torsion of the arm, producing various types of fractures. In children, fracture of the shaft of the long bone are often green stick fracture in which there is disruption of the cortical bone on one side while that on the other side is bent. This fracture is so named because the part of bone do not separate. The bone resembles a tree branch, green stick, that has been sharply bent but not disconnected. In a transverse fracture of humeral shaft, the pull of the deltoid muscle carries proximal fragment laterally. Transverse fracture of humerus. Indirect injury resulting from a fall on outstretched hand may produce spiral or oblique fracture of the humeral shaft. Overriding of the oblique end of an obliquely fractured bone may result in shortening of the limb. Because the humerus is surrounded by muscle and has well-developed periosteum, properly aligned bone fragments usually unite well. An intercondylar fracture of the humerus results from a severe fall on the flexed elbow or with high-impact injury such as in a motor vehicle accident. Olecranon of the ulna is driven like a wedge between middle and lateral part of the condyle of the humerus, separating one or both parts from the humerus shaft. Following parts of the humerus are in direct contact with the indicated nerves. Surgical neck is direct contact with the axillary nerve, radial groove in the radial nerve, distal end of humerus, median nerve, medial epicondyle ulnar nerve. These nerve may be injured with the associated part of humerus fracture. These injuries are discussed later in this chapter. So this was all about fracture of humerus, clinical anatomy. Thank you.